Welcome back, Health Impact audience. We've got a treat for you again. Coming back to visit with us is Dr. Lina Wen. And of course, those of you who watch almost any television will see her all over the place. So we are just thrilled that she's able to spend some more time. Normally, she just gets 3 to 5 minutes on her interviews on regular television, but we'll get to talk to her for a good period of time to get really her insights on what's going on in the pandemic and how our hybrid healthcare world that we've all discussed most of the day today is really going to lend itself towards addressing some systemic problems that have been really exposed widely over the last year or so. We knew a lot of these problems were there before, but the pandemic has just exposed them even further, which sometimes when you expose a problem bigger, you can solve them hopefully faster and better than you could when they were just narrowly defined. So with that, Lina, can you just introduce yourself real quick, and then we'll jump into our first questions.
Of course. So glad to be joining you all again. Thank you, Shahid, for the nice introduction. So I'm Dr. Lina Wen. I'm an emergency physician. I also teach in public health and in health policy management at George Washington University. And as Shahid mentioned, I do a lot of work in the media with regard to COVID. I'm an analyst for CNN. I also write a weekly column for the Washington Post on health policy and public health. And of course, been informally advising local state governments around handling of the vaccine rollout, testing, and other issues, and also helping businesses with various return to work strategies as a senior advisor for Everly Health. And so glad to be talking to you all today.
Awesome. No, welcome, definitely. So let's start with the first part, which is, we're just 50 days into this administration. How are you rating their performance, not from a political point of view, but, are we getting the health benefits and moving towards the health outcomes that we've been seeking, or is there a lot still to be done from a planning and strategy perspective?
I think it's both. The administration certainly has its job cut out, right? Any leader coming in during the middle of a pandemic and at the crossroads of this economic crisis certainly would have their work cut out. I think what the Biden administration has done really well is laying out on day one a national strategy, making clear what the role of the federal government can be. Certainly, we're at a different point than we were a year ago, and the administration coming in has even more to do because of what occurred in the past. And so I think getting now that there is this piecemeal approach trying to coordinate a national strategy is certainly challenging. I think they've done a good job thus far with the vaccine rollout. Again, this was something where the previous administration did a fantastic job with regard to Operation Warp Speed in the development of the vaccines, but it's that last mile in getting the vaccines out that is really challenging. What I really appreciate of this administration is their prioritization of equity, embedding equity as a core metric. And with regard to vaccine rollout, they've been very attentive to what are the areas that if we just have speed be the dominant driving force, we're going to leave out many people. And so distributing vaccines, for example, to federally qualified health centers, making note of which are the areas that are underserved, scaling up the door-to-door outreach and mobile vaccinations, I think has been really good. And so I think that where they are falling behind them is, I think, with regard to data. We do not have data transparency, for example, around where the vaccines are going, which entity is particularly efficient at distributing vaccines, which ones are not, which ones are doing a good job when it comes to testing, which one is not. And I don't think that we should confuse equity with a lowest common denominator approach, as in you could target the areas, the populations that are the hardest hit, but still reward competition and those entities, private or public, that are the most effective at delivering for that kind of outcome. And I really hope in moving forward that the administration is much more attentive to outcome-based measures and not be afraid to have competition between different entities.
No, I love that advice. And in fact, if you look at it from last year, it was almost like an antagonistic relationship between what the commercial side was doing. And it's like, we can't depend on the federal government. We can't depend on our local environments. So we have to go do everything ourselves. So I love definitely what the administration is going. It's more of a partnership. But in that partnership, there is stuff that the feds have behind the firewalls that they're definitely not sharing. And so I love that. But let's talk about the health equity part of it. How much of that is really can just be started by the feds, but have to really be concluded, at the CVS's, the Walgreens, et cetera, where the vaccines are taking place. So how much is the federal government able to start this out, but it has to be finished by commercial? Or can commercial just take complete guidance from the federal government, because the data could be forthcoming if more was coming out?
Yeah, it's a really good question. I mean, ultimately, there is a general answer that I'm sure is the correct answer, which is that, of course, this has to be a partnership. Right. This can't be one versus another. But I think here's the nuance here. Having worked, I was previously the health commissioner for the city of Baltimore, so I have worked in government and understand the struggles of a way overtaxed, overstretched public health system as well. But I think a lot of people, as you were saying, kind of set up this antagonism of, well, public health is what private health doesn't do, or the public system is so slow, we should let the private systems take over, or even the federal state approach. Federal government, what is their role versus state and local government? Obviously, it should be a partnership approach. But let me get down to the specifics of what that could look like. The federal government could mandate that all entities that are delivering vaccines, let's say, provide a full accounting of what's happening at the end of the day. As in, talk about how many vaccine doses did they have at the beginning of the day, how many were given out, how many were thrown out because they were wasted, because somebody didn't show up for an appointment. What are the exact demographics of the people who came, divided by race, age, where they came from, what kind of worker they are, if they are an essential worker or not. I mean, why shouldn't these entities all be collecting those information and then reporting it back up? That way, there can be a public accounting so that individuals can see. And I believe that doses should be allocated accordingly. If you see, for example, that there are 2 pharmacies in the same city, one is, they both get 200 doses, let's say, but one by the end of 3 days is done with all 200 doses. The other one after a week still has 100 doses left. And by the way, when you compare the demographics of people receiving these doses, one is giving out the one that's really efficient is also serving those in an underserved area. And the people who are coming to get the doses are not driving in from 80 miles away. They're people who are living in that underserved community. Then you know that that pharmacy is doing something right. What are they doing? Are they also doing door-to-door outreach? Are they posting flyers? Are they working with church groups and community groups on the ground to get this out? I think we need that kind of public accounting. And then very importantly, we need to be allocating doses and vaccines to people who are efficiently getting the work done. Again, let's not confuse equity with lack of competition. We should be rewarding those entities that are delivering on the outcomes that we care about, including core equity metrics too.
Yeah, and when you look at, I've often made fun of us in the health IT community that Amazon can track a box of cereal better than we can track some of these vaccines, and that's sad. It's not. I mean, it's a chuckling comment here in one respect, but it's sad in that we do have the data, we have the technology. What I think we're lacking is a little bit of leadership that will sit in between these areas and say, yes, it matters. And just because somebody didn't give me a data format or a standard to go work on, I'm going to collect it. We're going to put it into Microsoft Excel or CSVs, and we're going to upload it into Dropbox or Microsoft OneDrive. And then we're going to share that data with each other. Do you feel that level of just like day-to-day practicality should be practiced here? And if so, is this a leadership problem that the feds could help with, like bring together the leaders and say, all right, we're not going to have a 3-year standardization effort to go make this happen. What can you guys do by Friday? What can we put it into place? Because we know we are far more resilient than we ever thought possible. We know we can move faster than we ever thought possible. We just have to decide that it is important to be done. So what could we do about this data collection quickly rather than wait for some standardization effort to come out?
Yeah, I think you hit the nail exactly on the head. I think people are waiting for someone else to step up. And we know that there is inertia because people, frankly, are really busy, right? People are really busy getting the vaccines rolled out and everything else. And so people are just, there isn't this urgency to step up. I think that leadership could certainly come from the federal government, again, mandating these data to be reported. Local officials and private industries are used to being regulated. They know that they have to produce data by a certain point. So the federal government can very easily use the hammer and say, do this or else we're not going to give you vaccines next time. They can definitely do that.
Okay, so that's the hammer. So it's not a regulatory problem. It is, I'm not going to send you any more vaccines unless I get the data from your prior batch.
Exactly. And guess what? Those data will be forthcoming immediately because people understand that kind of requirement. Again, we do this all the time. In delivering healthcare, we produce the data on which patients we're seeing, what medications are being given out. So we know how to do this. Let's do that. There's another lever too. And that I think maybe Shahid is getting to the point that you're raising about what can individuals also be doing. This doesn't have to just come from the federal government. Yes, it should come from them. But in the meantime, why not have every Walgreens, every CVS, every entity that's giving out vaccines, why are they not producing the data themselves? Yes, it may not be a direct comparison because Walgreens can't necessarily force CVS to produce those data, but you can imagine that there may be a competitive advantage if Walgreens is saying, give us more vaccine and here are the data. Here's why we should be getting more vaccine because we're using up 100% of our allocation within 5 days of getting the shipment. That's one way of making your case. Or they could say, look, compared to the rest of the data that we have, maybe the rest of the city, everybody else seems to be vaccinating only 3% of African Americans, but we're vaccinating 10% of African Americans. Here's what we're doing. Give us more vaccine. We can reach these target communities because we are successful. I think private groups can also do this too. If there are public-private partnerships, if they are individuals, for example, a pharmacy that's helping a homeless shelter, and that part, or a nonprofit that's working with some other a startup that and they're doing vaccine distribution, they can make clear what it is that they're doing, publicize those data, and really make the point for why they should be getting more vaccine to be giving this out. So I think this is a solvable problem, but somebody has to step up first.
That's right. And I think that someone, as you look at leadership, there is this question, and we don't want to use the HIPAA boogeyman because we're not saying tell whether Shahid got the vaccine or not. We're saying, did somebody that is in the demographic of Shahid get the vaccine or not, right? That's what we're saying. So this should not be a privacy issue. It should not be an issue where, we're letting out HIPAA information. So just wanted to make sure we were clarifying that because that's not at all what either one of us are asking about. Do you feel that, and I think these will get worked out. We may not get the data as fast as we want to, but it will come. What about the problem of the vaccine deniers at the moment? What are you feeling? We don't even have that much data other than general polling about, who is currently denying vaccines or maybe not on the side of vaccines. We're hearing all kinds of weird things like lots of healthcare workers might not want it either. What are you hearing and what do you think is reality with respect to the denialism of vaccines in general for COVID? And then tying that to the science denialism, that is a little bit broader question. So first part on the vaccine, what are you hearing and what do you think is real?
So two things that I want to raise here. One is that vaccine hesitancy is sometimes used as an excuse for why certain communities are getting vaccinated at lower rates. And when you look across the country, demand is much, much, much greater than supply in basically every part of the country. And so when you look, for example, in my city in Baltimore, 62% African-American, the vaccination rates in Baltimore is lower than all the surrounding counties. And there is a tendency, we've heard it from our leaders even saying, well, it's because of hesitancy in the community. Actually, when you talk to community members, to patients, to community leaders, they are seeing this pent-up demand. It's that people can't figure out how to access appointments, that there are vaccination sites in our city that people from all the rest of Maryland are coming to, but our own city residents are not able to access those sites. We have 11 acute care hospitals within Baltimore City. The allocation from the state, it counts those allocations to the hospital as part of our overall allocation. And what happens though is that the people using healthcare services in the hospital are not just residents of the city, they also live in surrounding counties too. And so when I have an issue with the concept of vaccine hesitancy right now, because I think it's being used as an excuse when the real issue is access, and we should be working on access. That said, the question that you raised about hesitancy is a real question, because there are a lot of people who, for whatever reason, are not certain that they want to take the vaccine. There are people who are, as you said, deniers of science and may not be giving their kids vaccines and all kinds of things. I actually don't want to talk about that group for the moment, because that's not the group that we're going to be able to easily sway.
Mm-hmm.
I think there are a lot of people who have concerns for a number of reasons. They may think that the vaccine development was too quick, in which case we can say to them, actually, there were no shortcuts taken in the vaccine approval, no shortcuts taken in scientific development. There are people who may have heard certain things that we can debunk. For example, some people thinking that they can get coronavirus from the vaccine when actually it does not contain a live virus. There's also confusion about where to go. Some people may be saying, well, let me wait. I think a lot of the vaccine hesitancy will go away over time, especially you mentioned with healthcare workers. I think as healthcare workers are seeing others around them getting vaccinated, I think that type of, well, I think a lot of people are just saying, I don't want to go first. It's not that I have a problem with the vaccine, it's that I don't want to be the first to get the vaccine. And so I think some of those issues are going to go away on their own as well. But I also think that over time, we just have to be careful about not blaming the individual when actually it's a systems problem that's at fault.
Interesting. Yeah. So two things to focus on here is, it's great to hear that you're not thinking that we're not buying the poll that there's a bunch of people that don't want it. I don't buy those polls. I think there's definitely much more demand right now than there is supply. So that's good to hear. The second part of it, though, is what could the head of a hospital system, the chief C-suite of hospitals and the team leaders, what could they do in their communities? Should they be going out to the communities and talking at churches, et cetera, about this issue, bringing them in and having group sessions? What do you generally recommend for this public-private partnership that has to occur to convince the community that not only is it safe, but you got to do it rapidly if you want anything to happen to the pandemic? If you don't do it rapidly and the variants kick out, now it's going to just take a little bit longer to fix the problem. So what should leaders be doing?
I think there are two main things. One is exactly what you said, which is figuring out who are the trusted leaders in your community. Understanding, again, it's not a monolith. Some people, it might be their church leader. Others, it may be teachers, it may be pharmacists. I would partner, if I were a hospital executive right now, I would look to see, can I do pop-up clinics with trusted community groups? Can I partner with a church, not just to come and give a talk? I actually don't think that that's the right approach. I mean, it's not going to hurt, but I think you want to bring vaccines to people. I would have a vaccination drive with a church where the pastor rolls up their sleeves first and gets that first vaccine. And that church ideally also works with the rest of the community to get as many people in the community to get vaccinated there. I would partner with a school, have a pop-up vaccination drive at the school for the parents of the kids at that school. So I would look at opportunities like that to directly bring vaccine to people. The other thing that I would do too is I would start talking to businesses and see what is the soft pressure that I could apply in order to encourage people to get vaccines. As in, would it make sense? I mean, you could imagine for cruise ships, for example, that cruise ships may very early on want only vaccinated people to be on a cruise ship. But what about restaurants? Might there be, and there have been ideas floated around this, might there be a vaccination night at local restaurants where only people who are fully vaccinated are coming to have dinner on that night? I think that there are a lot of freedoms that the CDC at the time that we are talking about this has not yet released guidance on what fully vaccinated people can do. And I'm sure that guidance is going to also evolve over time. But I think the more that we can be framing vaccines, not just as eat your vegetables, protect other people, that is true. You're protecting yourself and protecting other people by getting the vaccine and saving lives. But I think a lot of people are going to be motivated by a different interest, which is, what can I now do now that I have the vaccine? And I think working with industry and private groups on understanding what those things are and actually encouraging the liberalizing of restrictions once people are fully vaccinated, I actually think that it's that type of soft convincing that's going to make the biggest difference at the end of the day.
Yeah, and so when you look at hospitals and health systems, they've already been bombarded with more work than they've had to do in the past in shorter periods of time. Budgeting has been very difficult as well, obviously, because they're losing a lot of revenue. But what are you thinking with respect to the burdens and who should bear this? So physicians, nurses, et cetera, have already borne probably a lot more burden than they deserve to over the last year and a half. So we can't be asking them for more. Who are the others that are ancillary to them, so that we don't, we have to get them to continue to save lives, et cetera. But there's got to be people around that is not just the C-suite, but other folks. Who are other department members that could go out and be engaging with communities like you're suggesting?
I cannot agree with you more. I think that the clinicians are already doing their part. We've seen in this pandemic that the front lines of the pandemic are actually not even the ERs. I'm an ER doc. It's not even the ER. The front line is actually the community.
Mm.
The front line is what happens before you get to the ER. And this is going to be the same when it comes to vaccination. And what that means is every member of the hospital staff has a role to play here. The clinicians can certainly in their own free time do that. But I would say accountants, people who work in normal desk jobs, they are going to be the ones, project managers. We need people who are project managers more than anything if we're setting up a vaccination drive at a school. Yes, you might need someone to actually deliver the vaccine, but you also need people to set up the logistics here. And so people who are experts in logistics and operations, those are the individuals who are going to be on the front lines now leading this effort.
Yeah, no, that's a great advice. I didn't even think about it that way. These are all just little projects, right? So it's a great way to consider that. So now let's talk just for a couple of minutes that we have left about what are you feeling as the biggest issues that we need to start looking at as people start to get vaccines over the next couple of months, and the healthcare system starts to open right back up. What's going to likely happen is people who needed healthcare services are going to come back even further, which means that the burdens on the poor physicians and the nurses, et cetera, we thought, they were supposed to get a little bit easier after the vaccines come, but I think it's actually going to get worse after the vaccine has been given out and people start coming in. Do you feel that there's going to be this onslaught of more utilization of the healthcare system, and that there's something that our leaders can start to plan for today for that, or you kind of have to wait to see what happens?
I think we're already seeing that. We're seeing that after this massive surge over the holidays of COVID cases, that many hospitals and ICUs are still filled, but the proportion of COVID patients to other patients has really shifted. I think patients have been delaying their routine medical care. They may be sicker than before. I also think that there's just all this emphasis on health. When is the last time that we had health as the lead story in the news every single day? If people are thinking now about health, I hope that it means that people will be more attentive to long-standing medical issues, to preventive care. So I actually hope that there will be more utilization of healthcare services coming up too.
Yeah, and when you think about the hybrid nature of where healthcare is going, does that mean that we should, like health system professionals, especially at the C-suite level, should start reaching out to more telemedicine, more hybrid types of care, so that the onslaught doesn't come physically all into the same places? So do you feel like this means more telemedicine should be happening, and that we should go back to government and start to say, no, we need the emergency use authorization for HIPAA relief as well as telemedicine relief for longer, so that now we're not taking care of pandemic people, we're taking care of post-pandemic, where we ignored a bunch of stuff from before, and that's why we need the telemedicine, not for the other pandemic related things. What could we do there to help plan?
I think that's a terrific idea. I think we should have more telemedicine, more home-based care. And the driver, as you said, is not, I think framing it in terms of infection is just not the right approach, especially as we're getting more people vaccinated. But I think I think we can frame it in terms of neglected health issues, also in terms of people have now changed their preferences. And we know now that we can deliver care effectively using these other modalities too. So this is a way to increase access. It's not replacing brick and mortar. It's not saying never go into your doctor again, but it's saying what is it that we now know you can replace a lot of these in-person visits. So we know that there's also a lot of unmet need. And so how do we scale up and meet those unmet needs? It's a combination of these things. And so I think that is something we should take away in our advocacy and our daily practices too.
And should there be, would you suggest that health system leaders get together within their communities and make specific asks of the federal government? Like, I would not tell them to do this 6 months ago, but today you have somebody actually listening. So how should leaders get together? What are the kind of things they should try to decide and organize amongst themselves so they can make an ask of the federal government? Something as simple as telemedicine, of course, is there, but what else do you think that they should be asking for in an organized approach of the feds or local governments that is more likely to be listened to today than it was 6 months ago?
I think all the levers are on the federal level. I think local government really they're stretched beyond anything. And I don't really know what it is that they could offer. I think all the asks that one would make are on the regulatory level. And I am actually quite certain that hospitals and FQHCs and others are already getting together to make such types of asks.
Yeah, that's great. In the last minute, is there any suggestions or advice that you have for health system leaders about what they might be doing better with respect to how to prepare for the summer and fall? Like what they might not be thinking about that is going to happen in summer and fall that they really should be thinking of to be able to prepare?
I would imagine that everybody's already thinking about this issue of when they're going to be requiring vaccinations of their staff. I think that, I mean, again, it's hard to do that before the vaccine is officially approved, but it is something that one could imagine coming down the pike. I also think that longer term, there needs to be more conversation about the social determinants of health, recognizing that public health is not, I mean, certainly when we don't do it right, we see infections be out of control, but public health is about much more than pandemic preparedness. And so understanding the role of public health in the social safety net is pretty important too.
That's awesome. No, we really appreciate your advice, and our time flew by as it normally does with you. So this was excellent advice. And I think when you look at, for our Health Impact audience, there's a bunch of health IT, technology, and non-technology things that we can start helping with, collecting with data, helping coordinate the response between hospitals and health systems. But more so, I think this idea, hopefully post-pandemic will go away, that we have this public-private community partnership that we really, really need for health system professionals to help try to lead. With that, we're going to go ahead and turn us over to our next panel. Thank you very much, Dr. Lina Wen. We'll see you in our next Health Impact.
Thank you.